We'll get started. Thank you for joining us today for the class of 2021 thesis presentations. I'm Corey Sandone, the director of the Department of Art as Applied to Medicine, and I extend this welcome on behalf of the faculty in our department, David Rini, our graduate program director, and the 7 students who will present today. This is always my favorite presentation of the year, a culminating event for our soon to graduate students and an opportunity to see what they've been researching and creating this past year. We'll go over a few requests for the audience. Remember the days of yore when we simply asked everybody in the auditorium to silence their phones? Well, each presentation will be followed by a question and answer period. For our YouTube audience, please type your questions into the comment section. Because we have 7 presenters, 3 of whom are named Emily, we'll ask you to put your topic as the first word of your question, so we know which thesis presentation your question pertains to. Daisha will read selected questions to the presenters. We also have a small Zoom audience at Hopkins. We're asking that group to close all the programs except Zoom for optimal performance. Please mute your mic unless asking a question during the Q&A. Finally, if you're a faculty member in another department at Hopkins who's interested in serving as a preceptor for a student thesis next year, please reach out to me. I would be happy to discuss your project that has a visualization challenge requiring original research on the part of the medical illustration student. It's my pleasure to introduce our first speaker, Emily Slapin. Emily earned her BFA from Rhode Island School of Design and has a strong interest in women's health.
Thank you, Corey. Hi, my name is Emily Slapin. My preceptor is Dr. Vered Stearns, and my thesis is Reimagining Delivery of Midlife Women's Healthcare. There are over 150 million women living in the United States. Their life expectancy averages into the mid-80s, and they spend 1/3 of those years post-menopause. While many women welcome this transition, the silence and stigma surrounding menopause can cause women to not seek treatment for symptoms such as hot flashes and mood changes. Existing models for delivering healthcare to this demographic are insufficient for several reasons. Programs targeting this demographic are either scant or non-existent. The majority of women's healthcare focuses on the childbearing years. Physicians are the most common source of menopause information, but only 6% of physicians feel adequately prepared to treat women experiencing menopausal symptoms. As a result, 42% of women change health providers in midlife because they are dissatisfied with their care. The Johns Hopkins Women's Wellness and Healthy Aging Program is a new initiative that provides comprehensive, patient-centered, interdisciplinary care to women in their post-reproductive years. They make excellent healthcare more accessible by offering streamlined visits, coordination and communication between providers, pre-consultation testing, and a personalized patient roadmap. The goal of this thesis was twofold: to discover the best way to introduce this new model of healthcare to the target patient population, and to create appealing visuals to engage potential patients and referring physicians. We held 3 rounds of patient stakeholder feedback over Zoom. The feedback was solicited at the beginning, in the middle, and at the end of the project, and it informed both the content and the format of the final visuals. The first and second rounds of feedback were cancer survivors who were instructed to view the materials through the lens of healthy aging, not a diagnosis. The last round was a group with no comorbidities. We also conducted a survey over SurveyMonkey to get input from a larger audience. To create the visuals, I used Adobe Illustrator, Audition, After Effects, and Photoshop. The final project took the form of 2 short explainer videos and 20 illustrations for social media, such as Instagram and Facebook. We decided on short explainer videos because they are a great way to quickly convey a lot of information in a condensed form. Studies have shown that video consumption has increased dramatically over the last few years. And since they are about a minute in length, viewers are likelier to watch the entire video. The first animation introduces patients to the Johns Hopkins Women's Wellness and Healthy Aging Program. The content addresses some of the concerns that came up in the first focus group and explains how the Women's Wellness Program is addressing them. I will play the first animation now.
You're busy with family, with work, with life. Taking care of your own health and wellness takes time that you don't have. To monitor symptoms, make appointments, visit multiple doctors, get tests, decipher results, and coordinate your own care. The Johns Hopkins Women's Wellness and Healthy Aging Program is working to change this. Our new pathway to comprehensive coordinated care provides streamlined visits, coordination and communication between providers, pre-consultation testing, and a patient roadmap for personalized care. From your initial consult through continued monitoring, a patient navigator facilitates your experience and helps you establish relationships with providers. Whether you would like a one-time consultation to take back to your primary provider, a yearly checkup, or need ongoing care, the Women's Wellness and Healthy Aging Program can meet your healthcare needs. At Johns Hopkins, we are strong in aging.
The second animation is about healthy lifestyle decisions and addresses some of the other topics that patient stakeholders identified as priorities in both the survey and the focus groups. Here's the second animation.
Healthy muscles, joints, cognitive function, cardiovascular fitness, and emotional well-being are all important for maintaining a high quality of life. You want to feel your best, but you don't know where to start. At the Johns Hopkins Women's Wellness and Healthy Aging Program, we want to help you age well. Our providers will develop a personalized integrated plan to address your unique healthcare needs. Regular checkups, along with eating a balanced diet, exercising, limiting alcohol, and getting enough sleep, all play a key role in fighting infections, reducing cancer risk, and maintaining a healthy heart, brain, and bones. Our multidisciplinary approach will help you stay healthy through menopause and beyond. At Johns Hopkins, we are strong in aging.
These are some of the 20 social media illustrations created for Facebook and Instagram. They address some topics and concerns that could not be included in the animations due to time constraints. Here are some more examples. The illustrations are targeted towards women with busy schedules who have a lot on their plate. Feedback from the second focus group helped determine that short videos are an effective way to introduce a patient population to the Johns Hopkins Women's Wellness and Healthy Aging Program. Overall, most of the participants identified with the characters in the illustrations and said they would want to learn more about the program after watching the video. Some edits were made to the animation based on patient feedback. For example, in this scene, viewers had a hard time identifying the provider as a doctor. So I gave her a white lab coat and a stethoscope. I also rearranged the order to center the patient on the top. At the very end of this project, we held a third focus group to get feedback from friends and colleagues who had no comorbidities, since the first two groups were cancer survivors. While they also liked the idea of short animations and social media illustrations, they did not relate to the content or the characters to the extent that the first two groups did. The divisions fell mostly along race, age, and health status. Going forward, more focus groups and several rounds of iteration could determine the best strategy for reaching the entire target patient population. With such a broad patient population, it's difficult to be inclusive enough to appeal to everyone while being specific enough that each woman feels like the program is appropriate for her. One way this might be achieved is through more specific targeted ads at different subgroups, such as cancer survivors versus women entering menopause naturally, and women who are perimenopausal versus women who are postmenopausal. This project could not have happened without the help and guidance of many people. In particular, I would like to thank my thesis preceptor, Dr. Vered Stearns, my department advisor, Jenny Fairman, and content experts, Dr. Wen Shen, Dr. Jenny Sheng, and Kate Pisano. And thank you to all of you for tuning in and watching. If there are any questions, I would be happy to answer them now. So, questions, comments, thoughts?
Hi, Emily. That was really fun and really neat. I was curious, those social media posts that you showed, were those mock-ups, or did you guys already post them?
Oh, they were mock-ups. No, they have not been posted yet. Those are mock-ups.
Yeah, it'll be really fun to see how they do and see how people react to each one, and if they match up with some of your survey and stakeholder feedback.
Yeah, exactly.
And do you know where the videos are going to be posted?
On the website, when
Okay.
the website gets up and running. So, which it isn't yet, but will be soon.
I think your presentation was beautiful. It was succinct and clear, and the images fit right in with it. I think they're very readable, and the flow is even and consistent. I think it's a wonderful way to introduce patients to a new care facility.
Thanks, Gary.
Emily, this is David. Very nice presentation. I want to compliment you or commend you for tackling something that's so important in our profession, and it's something that is really on the minds of a lot of people, and that is diversity. I think that we as illustrators have such an important role to play in making sure that all the topics that we present in any context are appropriate for a wide audience and make everyone feel like they qualify for good healthcare. And I know this was a big part of your project, and I can see that you were really tuned into it and you gathered feedback about it. So I really want to commend you, and I'm anxious to learn more about what you learned from your focus groups. So well done.
Thank you. Yeah, that's good to hear, because that was one of the things that was important to me. So, and to the group and the program, to have a very diverse representation of women.
Hey, Emily, this is Morgan. As somebody who also did a patient education thesis, you did a great job of making something that's really approachable and, like David said, diversified for many, many individuals. So great job.
So, thank you. Great.
Emily,
Wow.
we do have a question from the YouTube audience. Diane asks or says, "Hi, Emily. Do you think that there is a correlation between a patient's overall experience with the healthcare system across their lifetime and the reactions to the video content you created?"
What was that? Do I think there is a...
Yeah. Is there a correlation, so not causation, but correlation between a patient's overall experience with the healthcare system across their lifetime and the reactions to the video content you created?
I think so. The patient population that we had in the feedback group typically had access to very good care. But one of the questions that we did have in the survey was what prevents you from accessing great healthcare? What has gotten in the way of accessing healthcare in the past? And one of the answers was lack of trust in providers. So that's definitely kind of a problem that needs to be bridged for certain people.
Thank you, Emily. There's also a second question, which was, is there a benefit to tune these to different cultural subgroups?
That is a good question, and I don't know. I think there's definitely a benefit in access in targeting perimenopausal versus postmenopausal women and healthy women versus women with a cancer diagnosis, because those were the two big things that came up. Some of the healthy women said, I didn't know if I could participate in this program unless I had a diagnosis. And some of the cancer patients were like, oh, I didn't know if this was for me since I am dealing with cancer, not healthy aging. So And then a woman who's 45 is at a very different stage in life than a woman who's 65. So age and health status were definitely important. And I think once those two are taken care of, that would, it'd be interesting to see the reactions to that. So awesome. Well, thank you very much, everyone. Next, you will be hearing from my classmate, Emily Cheng, who received her Bachelor of Science degree in neuroscience from UCLA and did her thesis project on the eye disease glaucoma.
All right. Thank you so much for the kind introduction, Emily. Hi, I am also Emily, and I'm presenting on my master's thesis, Visualizing Glaucoma, Accurately Characterizing and Depicting Visual Loss via Virtual Reality. I worked in conjunction with Dr. Pradeep Ramalu, his team, and Juan Garcia. We are going to wait for the presentation to load. Glaucoma is an eye disease that affects peripheral vision in more than 70 million people worldwide and can lead to irreversible blindness. The tests that diagnose glaucoma are well established, but the actual patient experience of the disease remains confined to epidemiologic descriptions and imprecise visualizations. In addition to that, patients diagnosed with early stage glaucoma are prescribed these lifelong therapies that are very difficult to adhere to because they initially experience minimal visual distortions. However, once it progresses to late stage glaucoma, their quality of life becomes severely impacted, and everyday activities like grocery shopping, cooking, or driving can become difficult and even be life-threatening. The objectives of this thesis, therefore, is to visualize glaucoma in a medium that can educate patients about its moderate to late stage impacts, and to have it act as a tool for family members and providers to offer more empathetic care and support. This was met through a two-phased IRB-approved process. The first phase accurately characterizes the visual experience with moderate to late stage glaucoma by developing a visual assessment protocol. The second phase depicts the visual experience within the VR setting and builds supplementary modules that can elucidate the data for the patient user. The three modules that I've made are listed here, the first being patient education, second being live camera, and the third as task simulator, which I will go into more detail later. To describe a little bit about the execution of this process, for phase one, I developed a method to accurately characterize the patient visual experience, and this is done by first obtaining IRB approval for a patient assessment protocol. The protocol involved developing a visual assessment tool to best capture the patient experience, and the assessment tool consists of three parts. The first is a visual assessment grid, which is developed based off of standardized visual exams such as the Amsler grid and the Humphrey Visual Field Test. The grid uses a focal point, which you see in the red dot in the center, to control the patient gaze and to better capture the peripheral distortions. The grid is then superimposed on a grocery aisle scene, which is a visually dense scenario patients could commonly face. I then prepared different visual distortions and based off of previous studies that determine the most commonly used glaucoma visual descriptors. The assessment tool is then administered to patients through a Zoom share screen on a 38-inch curved monitor in which the patient sits 60 centimeters away from. This standardized distance is calculated so that patients will have at least 70 degrees of vision from the point of fixation when viewing the assessment grid on the monitor. The distortions are then presented and then live edited based off of patient feedback to develop a fully formed representation of the patient's visual field. For the second phase, I focused on placing that resulting depiction in the virtual reality setting, and this is done by choosing a headset with novel eye tracking and foveated rendering capabilities. The headsets allow your visual field to follow your finer eye movements rather than the broad head orientation that standard VR headsets usually have. The corresponding software development kits, or SDKs, and scripts are novelly implemented to connect the imported distortion to the user's eye movements, and this allows the imported distortions to follow the viewer's shifting eyesight. Additionally, I developed several 3D models for the three modules. Several hardware and software were used to develop this thesis. Photoshop and Illustrator were used to develop the 2D assets. Blender, ZBrush, and Cinema 4D were used to develop the 3D assets. Animations were made in After Effects and exported in Media Encoder. And finally, Unity was used to compile everything into a virtual reality application. For hardware, we used the HTC Vive Pro I, as well as an MSI gaming laptop and a Mac Pro to run these programs and build the resulting thesis. For the overall results, beginning from phase 1 patient assessments, I documented 4 case studies, and the following resulting depictions with some simple descriptors will be shown here, excuse me. The first patient experiences cloudiness that is persistent when present, but not present all the time, and it takes on a cameo shape, as shown here. Patient 2 experiences black and white swirls that change under different lighting, along with characteristic slants that traverses their upper visual field. Patient 3 experiences an inverted J shape with an area that feels as if the patient is underwater. And patient 4 described their experience like peering into the void, or as if feeling as if vision is absent. For the second phase, I utilized 3D modeling software like Blender, ZBrush, C4D, and Unity to develop the following modules. The first is a main scene with a custom Unity skybox. The viewer is placed within the inside of the eye, and they have access to 3 different modules as shown in the screen recording. To go into detail for each module, the first is the patient education module. This module allows the user to access different animations explaining glaucoma. And here I am accessing the patient education module. I'm going to move a little bit forward to show the scrolling to access different animations. Here an animation is pulled up. And the module, as I move forward here, also has access to 3D models with corresponding labels that are meant to provide a better spatial and anatomical understanding of some of the topics addressed in the animation. For this thesis, I developed the introductory animation, which I will play a 30-second clip of now.
Glaucoma affects normal vision, and if left untreated, is the leading cause of irreversible blindness. In normal vision, light enters the eye and is focused on the retina. Several nerve cells in the retina, called retinal ganglion cells, detect the light and transmit signals through a series of nerve fibers exiting the eye, called the optic nerve.
Right? So we're going to move forward to the second module, and this module uses the front-facing fisheye of the VR headset to offer the viewer a direct comparison of their environment with and without the visual defect. As you can see here, the user interface provides access to different patient distortions, along with information about the patient condition. So as you can see, based off of, well, I'm going through the different types of access, and here you get a better view of the resolution of the camera, which isn't very high. So hopefully that will be a point of improvement as technology progresses in the future. And here you see me going through each of the patient distortions to show how the user interface pulls the distortions up. And I select patient 4 as the primary distortion to focus on. And if you notice, the movement of the distortion is a little jittery, and that's due to the fact that the image is tethered to the finer movements of your eyesight from the VR headset, rather than the slower, broader movements of the head. So for the final module, which is a search task simulator, this places the viewer in a virtually simulated living room and challenges them to search for a remote with a selected visual defect. The purpose of this task is to show the viewer that simple tasks like searching for a remote can become heavily impacted with visual field defects caused by diseases like glaucoma. If you notice the static in the background and what would be accompanying audio, that is placed there to amplify the frustration one might feel from delaying the ability of doing something they want just because they can't see. And as you can see in this recording, I go through the user interface, select a patient distortion, and I complete the activity with that distortion in view. So here I am trying to find a remote. And the timer is running in the background, and I'm going to skip to the end where I find the remote, and then you'll notice that the time stops. Overall, this thesis successfully implemented at a baseline degree novel use of the eye tracking software and scripts from Gaze Visualizer to simulate glaucoma in virtual reality. A patient-centered standardized approach was also novelly developed to capture patient visual field distortions in detail. And this thesis can act as a first prototype that has potential for further exploration. However, some challenges included variables that couldn't be accounted for partially due to the remote requirements of COVID-19. Some of those variables include the impact of lighting that could have differences and distortions, varying temporal behaviors of some of those distortions, as well as maintaining a consistent exam setup between remote sessions. Combining multiple standard software development kits and plugins can also be a source of instability. Some things to consider for the future include simulating glaucoma disease progression. This can provide educationally powerful information for the long-term experience of the disease. This thesis can also be applied to other ocular diseases, and the thesis itself could use further refinement of the user interface and the depiction of glaucoma within VR. I would like to take the time to thank my faculty advisor, Juan Garcia, my preceptor, Dr. Pradeep Ramalu, Alex, Grace, and Patrick for being an instrumental part of this thesis. Thank you so much. And I would also like to thank my friends and family, some of whom might be watching today, for being super supportive during this process. Thank you so much. And I would now welcome questions or comments.
Emily, this is David Rini. Quick question for you. How did you interpret the distortions? You explained them nicely and you showed them, but how did you confirm that those are close to what people with glaucoma are actually seeing?
So I didn't get the chance to actually address this in the presentation, but we hold multiple sessions with each patient that we interview. And during the first interview, we take notes and essentially live edit most of the presented distortions. And then later we follow up with them and they confirm or deny whether or not what we show them is accurate to what they're seeing. So most of it is a little bit subjective, but the way we standardize it is through the assessment grid and some of the previous terminology that was used based off of previous studies.
Your project goes so much deeper than this, but I say even just that is so valuable to see what people really face with glaucoma, just that kind of top level information that you present. So thank you. Very interesting.
Thank you, David.
Hey, Emily, this is Lydia. Congratulations. You've achieved so much in such an incredibly short period of time and working remotely. So that's just, yeah, I'm floored by how much you've done here. I had a quick question about the distortion as well. I was curious, do you think, are there plans in the future to potentially get some initial feedback from family members of individuals who are, living with people who have these defects and how it might have changed their perception?
I think it's definitely a very good potential route to take. One thing that was discussed in the beginning of this whole thesis was the idea of possibly surveying patients and their families to get their feedback on how this app would impact their perception of the disease. But we haven't really gotten to that point yet. But I think that definitely is a route that is worth taking. But thank you.
Congratulations.
Thank you so much.
Emily, did you get any feedback on whether the users preferred the photographed room that you used or the 3D model created room, that the living room?
This thesis didn't actually present any of the virtual reality simulation to the patient. So most of the interaction with the patient is through the interview process where we capture most other distortions, and then the importing of those distortions into the virtual reality application hasn't gotten to a point where we could present them to the patient, mostly because we are in a remote setting and it's pretty difficult to handle the logistics of cleaning the VR headset between interviewing patients. So that was a plan for the potential future.
Thank you.
Thank you.
Hey, Emily, this is Jeff. The really cool project, and you learned so much. Could you share any insights you had on differences or similarities between working with a UI in 2D versus 3D?
Sure. Sure. That's a question worth thinking about. I think user interface is surprisingly pretty straightforward in 3D. I would have expected it to be a lot more daunting, but the learning curve for it, I think, is pretty similar to something like Adobe XD or just any other, or Adobe Animate. There's a lot of coding involved, but once you sort of get the hang of it, it becomes a little bit easier. And I also have to thank Patrick for this. He's my technical advisor. He helped me a lot with getting these components working.
Since I've been diagnosed with glaucoma, I think it would be interesting to show the progression in at least one of the cases, starting out with a very small blind spot and moving deeper as the disease progresses. But it's beautiful and it was very educational.
Thank you very much, Gary. I agree.
Emily, we did have a couple of questions from the YouTube audience. One question says, what other medical conditions might be more easily explained in VR? With a follow-up of, why did you decide on glaucoma as your topic?
Thank you for the questions. So the first question, in terms of what other visual defects could be well portrayed in VR, I am definitely not an ophthalmologist, but from the research that I've done for this thesis, I think VR does have a lot of potential for displaying visual loss for within the central field. So stuff like macular degeneration, I think, could really convey something impactful in VR. For glaucoma, this is more centered on peripheral loss. So having to depict that or find a way to depict that in a VR setting is a little bit different. In terms, for the second question, how did I pick this? I did not choose this topic, but I was very fortunate to be presented with it by my preceptor, Dr. Pradeep Ramalu. He created the structure and got this study IRB approved, and then I sort of hopped in and then worked on building the assets for it.
Sorry, Emily, go ahead.
Oh, sorry, no, nothing. I was just mumbling to myself.
Okay, a second question is the curved screen an initial display for the VR? And does the resolution of either device have anything to play with your results?
Can you repeat the second part of the question, please?
Sure. Does the resolution of either devices have anything to do with your results? Does it play a part in your results?
That's interesting. That's not a question I've thought of. In terms of the curved monitor, the reason why it's curved, it does play a role it does play a beneficial role in reducing the amount of peripheral distortion you'll see. Typically for a standard eye exam for patients with glaucoma, you peer into like a globe. So it's more like curved. So ideally, if we were to present the patient with an ideal exam, it would be through a globe. So the best way for us to mimic that would be through a monitor that has some curvature on the sides. In terms of the resolution, I think the best thing I could think of right now is that the higher the resolution, the better. Usually low resolution can lead to like loss of information that would end up being inaccurately captured later on, or could be inaccurately interpreted. So I hope that answers that question. I appreciate it. Appreciate the questions being asked.
There is a third question. Are the blind spots perceived by the patient somehow affected by the luminosity in the room? And is there something that could be integrated in your, is the luminosity in the room something that could be integrated into your VR project?
That's a great question. I think definitely lighting does play a role in the distortion that the patient ends up seeing. One patient that we interviewed described feeling like their blind spots are a little bit lighter in bright daylight and a little darker in like room within a room or in darkness. So ideally, we would be taking this thesis to incorporate that information, but it just wasn't a variable that was measured specifically during this interview process. So I think in the future, we would be taking like a light measuring device to figure out the lumens that were in the room that we interviewed them in. And then from there, capture more data before placing it into the VR setting. Okay. Well, thank you guys so much for the questions. That was very kind of you to ask. I would now like to introduce my talented cohort mate, Kurt Eisenwein, who received his BA in Biological and Pre-Medical Illustration from Iowa State University, and is going to talk to you a little bit about the famous fossil, Lucy.
There we go. Thank you. Okay, hi. Yeah, thank you for the introduction, Emily. My name is Kurt Eisenwein. I'm a grad student here at the Department of Art as Applied Medicine, and this afternoon I would like to present to you my thesis, Walking the Line, examining an illustration of AL2881 for anatomical accuracy and its implications for studying Australopithecine locomotion. This was done with the help of Dr. Adam Sylvester, who was the preceptor. So you're probably familiar with AL2881, though you might not know it. So there's a bit of a delay. Okay. All right. AL2881 is, for those who don't know, the very famous Lucy fossil. It's the first specimen of Australopithecus afarensis. This fossil has been crucial to the study of many aspects of human evolution, and one of them is bipedalism, or how we came to walk about on two legs. Now, there's little doubt that Lucy could walk on two legs, but since her discovery, there has been an ongoing debate over how she walked. Was her gait more like our own, always on two legs, or was it more like a chimpanzee who can use the hind legs but only for short distances? So the folks who agree with the chimpanzee side are proponents of the bent hip, bent knee walking hypothesis. But there is an issue with this hypothesis. It is partly derived from a reconstruction of the pelvis, but more than that, it's from one single black and white line drawing of the reconstruction. So on the lower right, you see the full figure, which first appeared in an article by Stern and Sussman dating back to 1983. Specifically, the issue with this detail, it's with this detail showing AL2881, it's depicting the sacrum and the ilium, although all that's seen of the ilium is the iliac crest. Since its publication, this drawing has had a share of skeptics who suspect this arrangement is not anatomically possible, yet the drawing has never been checked for anatomical accuracy in its 38 years. So if the skeptics are right, and it is anatomically impossible, then the bent hip, bent knee walking hypothesis may need some revision. So the goal of this project is to finally check the accuracy of the drawing. And the idea is to put together a 3D model of the pelvis and try to orient it in a way that matches the drawing. Is it possible to orient a three-dimensional model in a way that duplicates the view that is shown here? The strategy for this is broken into three different phases. First, we needed to make the model. And there is CT data of AL2881 in existence, but we were unable to obtain it. So instead, the Center for Functional Anatomy and Evolution here at Johns Hopkins provided casts taken from the original fossil. I'd like to also point out here that the os coxa and the sacrum are two separate pieces that will need to be joined. In collecting references, I took many photographic references, but they were only useful for so much. And that's for a very important reason that we'll get back to at the end. To get the CT data for our model, though, we had the good fortune of using an ultra high resolution CT system here at Johns Hopkins, one of, I believe, only two in the country. So with that, we scanned the casts. And so now we have the data and we need the software to read it. So the data arrived to us as STL files. The first task was to fit the sacrum and the innominate together properly. And to do that, we used a MIRA, which could isolate the area where the bones connect, and it has a way of mathematically calculating the minimum sum of the square distances between the two vertices. Basically, we have a very trustworthy fit. With the with the pieces in a proper fit, they were brought into ZBrush, which is a 3D modeling software. It's quite popular, and it has a feature that was perfect for this. It's called Spotlight. And it was perfect for manipulating the model behind the superimposition of the drawing. And the last task was then to compare the drawing with the model and see if we could find a way to align them. In the end, after all said and done, I ended up with a 3D model of Lucy's pelvis, 3 turntables, which we'll see next, a comparison of the model and the drawing, and in response, a new ink drawing of my own. This project also ends with a lot of opportunities for future projects. And here we have one of the final results. This is the 3D model of the AL2881 pelvis. In this one instance, I've given it kind of a bony material along with some lights and shadows to bring it to life a little bit. But for the actual work though, when making the actual comparison, the model was not retouched. The data was left in its raw form for the sake of accuracy, because polishing the model ran the risk of distorting the geometry, possibly warping some edges, and the edges are crucial to the comparison because of the line drawing. So we wanted to give the illustration the best possible chance of matching our model. So we'll see that more raw form in these turntables. So here's the first, it was along the transverse plane. Turntables are a way to see the model in 3 dimensions without needing the data or any kind of specialty software. The idea is that it shows a 360-degree rotation, but it shows it as a movie clip. So that way you can just pause the movie on the frame that shows the feature that you're looking for. And one more. As I said, I have done no sculpting of the model here. I want to keep the edges as close to the original as possible because edges are all I have to work with in a line drawing. So here's the comparison to the best approximation that I could find. The transparent line drawing was in a fixed position and it was never altered. And that left me free to manipulate the 3D model behind it and try to find a match that way. Now, there were no computer automated formulas to find the best fit here. This was hours and hours of trial and error. And to cut down on some of the confusion, I used some landmarks to stay oriented. These are the landmarks I use most frequently. The sacrum had the most detail in it and the most recognizable parts, so it was generally a good starting point. On the right, you can see the superior articulating facet. And to me, it had the most distinct shape and that was the most clearly delineated. So I figured if I could align the facet on the model with the facet in the drawing, that could serve as an anchor point. And then how could I rotate the model so that the other landmarks are also aligned while the articulating facet stayed in place? And in the end, this was found to be impossible. When one section would align, another would always be off. So there is something fundamentally flawed here. it's not physically possible to match the Stern and Sussman drawing to our new reconstruction of Lucy's pelvis, which leads to the key finding. The pen and ink line drawing that appeared in Stern and Sussman's 1983 article on Australopithecine locomotion is anatomically flawed and cannot be used to conclude the nature of bipedalism in Australopithecus afarensis. Here I have done a weighted line drawing in the manner of the original artist and at approximately the same angle. The difference is that it has been traced directly from our own 3D model, and it also includes the entirety of the os coxa, not just the iliac crest. And finally, there's a look at 3 in comparison. So what did we achieve by doing this? Well, we achieved what we set out to do. The drawing was checked for the very first time. And to the best of our ability, we could not find a way to match it to the modern reconstruction that we have from our CT data. There were some limitations encountered in this project, obviously. The first would be the COVID pandemic, which limited access to source materials. Just to see the casts in the functional anatomy and evolution laboratory was an involved process. So I couldn't just refer to the original casts anytime I wanted, which I would prefer. And I had to put all my trust in the model that we made. And this is a little dicey because I suspect source material is also the issue that led to the flaws in the original drawing. So I contacted the original artist, that's Ms. Lucy Betty Nash. Apologies if I'm mispronouncing that. And to make this drawing, she was given photos of the fossil, not the fossil itself, but photos, and she had to rely solely on those pictures to make the illustrations. Photos are not an ideal resource for the kind of art that needs to be so exact because the subjects are so easily distorted. So by way of example, here's a comparison between the 3D mesh of the sacrum and the photo that I took earlier. Now, ZBrush claims that it displays the model in true perspective, like an objective reality. The lens of the camera, however, leaves you with something slightly different. And if you just saw the picture on its own, you might not notice, but when you compare it to the real thing, there are proportions that are different and they do matter. So by way of closing, I want to point out that the result we obtained says nothing about Lucy's bipedalism, only that this particular figure is distorted. One would need to find in what way it's distorted to know how it affects the bent hip, bent knee hypothesis. This model can also be used for a host of other projects that push this idea further. 3D printing was one avenue. Muscle reconstructions and animations are another avenue. There's a lot of potential for what you can do with this, and I'm keen to see what more could come from it. And there we have it. I would like to thank Dr. Adam Sylvester for posing such an intriguing topic and for laying it out so well. Timothy Phelps, he was my advisor, and I can't say enough about how he made himself available to me and got me through this one way or another. Special thank you to Juan Garcia, because the course notes from his ZBrush class were invaluable when I was doing this. Thank you to Lucy Betty Nash for her correspondence with me, and I learned a little bit about the process. And finally, thank you to Andrea Rabinowitz, who supported me through all of this. I am now open to entertain some questions and comments.
That was excellent, Kurt. A very, very fascinating topic. And I'm curious to hear if the scientific community were to, push the whole bipedalism hypothesis further, with the distortions that you talked about through the 3D imaging, but also would you have to consider the distortions of the fossil itself, like being compressed over time and, whatever conditions maybe Lucy had? Was there any consideration of those things in your study?
For our purposes, no. There is, you can see that plastic distortion that comes in fossilization. If you saw the sacrum, it was like really deviated to one side is deviated to the right, it looks like. So we didn't put those into consideration though, because it's a representation of the fossil, not necessarily the living creature. So just marking what we have in front of us. If that answers the question.
It does. Again, it was an excellent presentation, and it was, a very fascinating topic as well. Great job.
I think it's a novel use of the 3D technologies that are now available to us to check something that would have been done prior to those technologies. I'm wondering, Kurt, what were your explorations with regards to the variables of the field of view and the focal length settings that can be manipulated within ZBrush to obtain other depictions of the 3D geometry? And I'm wondering also, I'm assuming that you were using the perspective view on. Can you talk a little bit about these things?
Yeah, so ZBrush does have that capacity to, I guess, imitate various focal lengths as if you're looking through a camera. I played around with those a little bit, but it was also getting into like a whole nother area that I would not have time to go through. So that's another thing that I think would be good to try if anybody wants to take this up in the future. Yes, I as far as perspective view, yeah, it's just important to be careful that that there is kind of a dynamic perspective that can really stretch things, and it makes you think that you're in true perspective, but you're not. So yeah, it's take some care, but there are a lot of options to work this in different ways that might actually fit.
Kurt, alumna Caitlin Lindsay is listening on the YouTube broadcast, and she also did a project on different ancient skeletons, and she says, glad to hear you found the original artist for the line drawing. Can you elaborate on how later researchers were relying on the 2D drawing rather than casts or other methods of measuring the anatomy?
This would be, I think, Dr. Sylvester would be able to answer this better than I could, because this is also a question that I had. Something that I brought up is, why hasn't anyone just taken a picture? We can build models that we're pretty confident in how it fits together. So why this particular line drawing? I don't know myself, but it's, yeah, I wonder about that as well.
I'm happy to comment a little bit about that. This line drawing is really like the foundational idea behind it, but there's a lot of other anatomy that was then added on to this theory. And so people have focused on these other pieces, and maybe you're unaware that this is really the piece that's at the foundation of the entire idea, despite the fact that other pieces have been added on to the bent knee and bent hip hypothesis for bipedalism. And so they are evaluating it, but it's not quite as largely seen as the crucial piece of evidence that it actually is.
Kurt, this is Jeff. This is such a neat project, and I used to work at the Cleveland Museum of Natural History, where they discovered Lucy, so they always talked about Lucy. It looks like your drawing is slightly oblique. I was curious, like, if your team had discussed trying to position it in the position that the artist might have been going for, and then maybe we could see like the differences in curves a little bit more.
So what are you asking exactly?
Oh, sorry. Yeah, so it looks like, I think from your presentation, you were trying to match the exact view that the artist had, but she might have had some inaccuracies from the photography or something. I'm assuming she was trying to go for a very neutral view, and this one, it looks like it's just a little to the side. So I was wondering, like, if we turned it a little bit so that it's a little bit more AP, and we could compare the curves of, you know, the bones against each other a little bit more, if that's what they're using to determine the bent hip knee hypothesis.
It's possible. It's possible that I went through some iterations of that, and when I was trying things out. Yeah, it's the original is in what I thought was a very strange configuration. It's not like a perfectly posterior view or anterior view. It's looking directly onto the top plane of that iliac crest, which is just, it's a strange, to me, a strange way to orient it. So this is my attempt at getting something like that.
Thank you. Yeah, and I appreciate, like, you must have spent hours trying to get just the right view you're looking for.
It's, yeah, it takes a very long time, because if something is, maybe it looks too short, that doesn't mean that it needs to be bigger in scale. Sometimes it means it just needs to be rotated because you're not seeing enough of the opposite side. So there are, you know, several different ways that something could line up or not line up. And it was, you know, admittedly an inexact process. So I encourage anybody to try this out for themselves.
I think that might be all the questions, Kurt.
Okay, I thought something was,
yeah.
Yeah, so great. Well, thank you all so much. Up next, we have Sora G. She majored in biology at the University of Wisconsin, and her thesis has been about creating learning experiences that will educate and train clinicians to ask for an autopsy consent.
Thank you so much, Kurt. I will be focusing on one of the most difficult moments for clinicians, which is during autopsy consenting. I thank my preceptor, Dr. Jody Hooper, for this wonderful opportunity. Autopsies at Johns Hopkins Hospital provides crucial information for families and medical advancement. All families of patients who have died at Johns Hopkins have the right to request an autopsy free of charge. This will require a consent of the correct family member, also known as next of kin. The next of kin, with the help of a clinician, will need to review and sign an autopsy consent form on the left. Without professional knowledge and prior experience, the form is very hard to digest, which is why it is very important that clinicians are prepared to communicate the significance and benefits of autopsy while showing clinical empathy to help families make more informed decisions. However, clinicians are often feeling unprepared due to two main reasons. First, the lack of training opportunities, and second, the lack of well-organized educational material. I tackled those two issues by designing a 3-component multimedia learning system. This experience starts with a web page which provides detailed knowledge. The information is then distilled into a mobile app and further distilled into a printed booklet. And altogether, the three components enable repetition and distillation of knowledge. We also wanted to include interactivity to make the learning experience more involving and therefore more meaningful. So after discussing with experienced Johns Hopkins clinicians, I decided to add a live action interactive simulation, which is role played by standardized patients. Standardized patients are professionally trained to react during in-person clinical simulations. And I saw this as a great opportunity to create an experience similar to an in-person training session, but also virtually accessible even during COVID. The interactive simulation is part of the training module webpage, and the pre-simulation introduction and the general recap will help review and summarize important information before and after the simulation. The simulation has 9 stages covering the entire consent request conversation, and I used a choose your own adventure style progression to present 1 question and 3 answer choices at the end of each stage. The options are either great, neutral, or poor, which won't be obvious, and the different choices will lead to different results and feedback. This is the setup for the live action filming. The photo shows myself in the back, then Dr. Serwant and Ms. Robinson Hendricks, our standardized patient. The recorded footage was edited using Adobe Premiere Pro, and then it was imported into Camtasia, where the interactive features were built in. I used Adobe XD to create wireframes for the second component, the mobile app. It has checklists, tips from Johns Hopkins clinicians, resources, and contacts. For our third component, the booklet, I decided on 3 illustrations that captured frequently asked questions. The first illustration shows the order of next of kin who can give legal consent. Second, whether an autopsy will affect an open casket viewing. And finally, the next steps the families should prepare for. And these are some rough iterations made to explore the organization and orientation. This is a summary of the main software and equipment used for filming, editing, interactivity, prototyping, and asset creation. Here is a final prototype website, which provides a well-organized interactive learning experience. We can see a link to the training module on the top, and below is some information for the autopsy service and the 3-component learning experience. Clicking on the module link will take you to the training module webpage, which has links to other resources at the bottom. Clicking on Learn More will take us to the educational material, where we can learn in detail about autopsies and autopsy consents. The side menu enables easy navigation, and let's say we want to start the interactive simulation. Clicking on the Start button will take us to the pre-simulation introduction, which covers necessary information through a few short quizzes. Following the introduction is the main simulation, and here is a video of myself going through stage 1.
This simulation provides interactive training for asking for an autopsy consent. We will follow Dr. Fullerton, a clinician at the Johns Hopkins Hospital, tasked to request an autopsy consent from Mr. Lee's wife. Mr. Lee came in for an appendectomy and has unexpectedly died. Mrs. Lee was notified a few hours ago, earlier today. How should Dr. Fullerton approach Mrs. Lee? Choose the best option to initiate or continue the conversation throughout the simulation.
Let's say I want to choose the first option.
Hello, Mrs. Lee. I'm Dr. Fullerton. I'm one of the doctors here at Hopkins, and I'm so very sorry about your husband's death.
I mean, I don't understand what happened. He was here for the appendectomy. I mean, I spoke to him yesterday, and he seemed fine. And now they just, I mean, he's died. and I don't even know what to think. I don't even know what to feel. I haven't even told our kids. I don't understand what's happened.
I am so very sorry that we're having to have this conversation. I can't imagine how difficult this must be. I think any death of a family member is so difficult, but especially when it's so unexpected. So one of the things I did want to talk with you about is to maybe talk through ways that we could try to get more answers and try to understand perhaps why Mr. Lee died.
Due to time constraints, I will skip a little bit.
Family who have had a loved one who dies at our hospital have the right to get an autopsy.
Dr. Fullerton made sure to check the charts and correctly addressed Mrs. Lee and properly introduced herself. Mrs. Lee was still emotional, but when Dr. Fullerton showed respect and empathy, Mrs. Lee was able to slowly open up to Dr. Fullerton. Dr. Fullerton understood that the word autopsy could initially be alarming. She slowly eased into the concept of autopsy and made sure Mrs. Lee understood that it was her right to request an autopsy.
Clicking on the continue will take you to the next stage. This is a prototype mobile application, which is easily accessible before and even during the conversation if the family is okay with it. Clicking on the application icon will launch the application. And let's say we want to check the checklist. The list is simple and easy to read. Some will have links to supportive resources, such as this. Attention was given to easy navigation through the expandable and collapsible list. And now let's say we have a quick question. Through the contact list, we can call different offices with just few taps. You can use the carrots on the side to navigate through different menus, or you can choose to go to the main page to navigate. Finally, the prototype booklet looks like this. It provides simple and non-traumatic visuals, which will be very helpful when clinicians are answering the family's questions. And it can be produced in different sizes if needed. And here are the illustrations included in the booklet. To summarize, the webpage provides an interactive and meaningful learning experience. The novel use of standardized patients helped us recognize their potential as great resources for future projects. And the mobile app is easily accessible, and the Pocket Guide can be helpful for both the clinician and patient families. With further development, these can be used nationally by clinicians, med students, and interested individuals. Helping clinicians prepare better will ultimately improve the experience for both the clinician and the patient's family during the most difficult moment, that is autopsy consenting. I would like to thank my faculty advisor, Corey Sandone, and preceptor, Dr. Hooper, for their generous help and awesome guidance, Vesalius Trust for funding the project, Dr. Serwent and Ms. Robinson Hendricks for the awesome role play, Jeff, Daisha, and Maggie for technical help, and all faculty and classmates for support. Thank you very much. Now I will happily take any questions or comments.
Hey, Sora, that was a very thoughtful thesis project, you know, from the Pocket Guide for the physicians to how you filmed it, you know, needing to social distance. I thought what you did with the split screen was great. And we could relate to both the physician and the patient at the same time. So that was a nice solution. I was curious if you had a chance to test any of your app design out or your interactive video with anyone yet.
That is a great future direction that would be awesome if we could take. There was also discussions on, I wasn't able to bring this up during the thesis, but there was also discussions on whether a live action film was more effective or a 2D animation was more effective for the interactivity. So testing those with clinicians, med students at Johns Hopkins, or even just interested individuals would give a great opportunity to see how well this could fit into the actual setting, as well as understanding which media works, which media would need more content to add, which media doesn't really work as well as we expected, or yeah, so it will give us great insight into that. And also it would be great if we could see some synergy moving here, because the reason why we had the 3 components was to repeat and distill the information so that this learning experience is more involving and more meaningful for the clinicians, compared to when someone just goes onto the webpage and reads everything and just closes it. So it will be really interesting if we do have the opportunity to do that, to see if there's a synergetic effect there. Thank you so much for the question. That was awesome.
I just have one more to piggyback, one more idea. To that point, I don't know how exactly you would do it, but it'd be interesting to find out from the patient perspective, or whoever's receiving the news perspective, if they notice a difference in how the information is delivered.
Oh, excuse me. What did you say on the first part, from a news perspective?
Oh, sorry. From the patient perspective, or from the person who's receiving the information, it'd be interesting if there's a way to test what any differences with this training module as well.
That would be awesome, because what's great about what you just commented on now is that this tool is initially meant for clinicians or med students who are training, but I see potential in this project being very helpful for patients' families as well, especially the 3rd component, the printed booklet. I think that would be great if it was produced in small cards so that the clinicians could hand out for families who need to prepare for next steps, or just have questions, but just who are unable to process all that information because they are grieving and because they still have to process everything that is happening. So if there is an opportunity to check that and see if the information, just to see how they take in the information, it would be really interesting.
Sora, that was an excellent presentation, and again, a very, it's a sensitive topic, and I feel like you really addressed the most difficult things. Kind of piggybacking off of Jeff's question too, this may be just more of a comment, but I think it would be interesting to assess how patients, if they notice a difference with the way that physicians are taught about this very difficult topic. There's different patient audiences that have different views about autopsy, and it would be interesting, I think, to look at that as well. So maybe not really a question, but more of a comment. Anyway, great job, and just a beautiful thesis.
Thank you so much.
From our YouTube audience, alumna Carrie Opert says, has there been any discussion about introducing the topic of autopsy or final wishes at hospital admissions?
As far as I know, there haven't been any discussions about that. I guess it would be very beneficial to both the clinicians and the family if that were to be implemented at Johns Hopkins. From the research I did for my thesis, I believe Mayo Clinic has a whole office that takes care of autopsy consenting, informing the families and everything. So if there could be a centralized system at Johns Hopkins, and we could also implement the tools that I have created, then I think there will, the experience would be very improved for everyone. But thank you so much for that question.
Hi, Sora.
Hello.
This is Tina from first year. Once again, this is really fascinating topic. I used to do consents for a study too. I just can't imagine how you would go about doing it for such a sensitive situation. I'm just kind of wondering, because you also mentioned that there are also booklets provided, kind of describing how the casket viewing, how the autopsy would affect the casket viewing. I'm just wondering, like, should the family member wanting to know more about how the autopsy is conducted, are there trainings provided for the physician so they can do it in an informative but also sensitive, compassionate way?
That is an awesome question, because your comment is also related to one of the core problems that has created this thesis. So upon discussing with experienced Johns Hopkins clinicians, it was shocking to me that, considering autopsy consenting is such a sensitive topic, I would expect there to be some kind of formal training, or at least some courses that the med students will take in order to prepare themselves for this topic. But upon discussing with clinicians, apparently they did not have any training before they started their residency. Currently, I am not sure if there's a proper training for clinicians to answer those questions in a very sensitive way, and which is why I have prepared the interactive simulation. And the good options will concentrate a lot on word choices and being really sensitive and empathetic while discussing those. And hopefully clinicians will go through the simulation if it is finally developed, and get a sense of how to discuss this very sensitive topic. But for now, just to answer your question, I don't think, it really depends on the clinicians. Did that answer your question?
Yeah, thank you.
Thank you. Sorry, that was a very long answer. Okay, so thank you so much for the comments and questions. Now I would like to introduce my wonderful classmate, Emily Wu. She received her Bachelor of Arts in Biology and Psychology from Washington University in St. Louis. And she will be presenting how she created media to teach MRI physics to radiology residents.
Hi, thanks so much for the introduction, Sora. So as she mentioned, I'll be presenting on creating media to teach MRI physics to radiology residents with a focus on preparing for the radiology core exam. Before I begin, I'd like to thank my preceptor, Dr. Erin Gomez, and my advisor, Jeff Day, for working with me over the past few months. To begin, radiology residents must pass the radiology core exam in order to become board certified. Additionally, the physics section is required to pass the exam as a whole. Approximately 30% of the core exam is comprised of physics question, and of that, 15% is on MRI physics. Despite the importance of physics in radiology training, there is a need for improved physics educational resources. In a 2008 survey of radiology residency program faculty, 39% desired more or better resources, and MRI physics was one of the top 4 specific areas named as having unmet needs. So to address the need for improved MRI physics resources, I had a few main goals. One, I aim to learn more about the needs of radiology residents in learning MRI physics, specifically for preparing for the radiology core exam. 2, I wanted to create new media based on the needs assessment results. And 3, design a future study to test different media presentation styles for teaching MRI physics. I started by distributing a needs assessment to current diagnostic radiology residents or recent graduates of the program at Johns Hopkins. After obtaining IRB approval, the survey was created and distributed using JHM Qualtrics and received 28 responses. The respondents' distribution by years of training can be seen in the bottom graph. On the right are examples of questions on the survey which asked residents about current MRI physics resources. I'll now share some of the results of the needs assessment before moving on to media creation. Residents rated question banks and practice tests as having the most helpful learning resources for MRI physics. However, the next most highly rated resources were web pages with animations, videos, and web pages with diagrams, suggesting that visual media are important for learning. Next, respondents named properties which defined a good MRI physics resource and were allowed to provide multiple answers. Although residents like practice questions the most, appealing visuals, simplified details, analogies or mnemonics, and animations were also frequently named as properties of a good resource. These are all features that can be incorporated when deciding on media format, script writing, and storyboarding. Finally, residents reported that problems with current MRI physics resources include being too confusing, lacking diagrams and animations, or being too complex. While I'm trying to incorporate all this feedback into the media creation process, I was also mindful not to make our explanations too simplistic. Overall, practice questions were rated as the most helpful, but visual resources, particularly animations and videos, were also important to the respondents. The needs assessment revealed that when creating a new resource, appealing visuals, analogies and diagrams, animations, and simplified details would be the most helpful. Following the needs assessment, I created a 10-minute animation on the fundamentals of MRI physics, written and narrated by my preceptor, Dr. Gomez. We worked together to iteratively refine the script and storyboard. In the process of planning the animation, I incorporated principles of the cognitive theory multimedia learning to improve learner outcome and reduce the cognitive load. For example, I made sure to always pair words, images, and narration together, both spatially and temporally. To create the animation, I used Cinema 4D, Adobe Illustrator, and Adobe After Effects. Cinema 4D was helpful for conveying 3D movement, which is important to teaching physics concepts. Within Cinema 4D, I created a 2D schematic style using Sketch and Toon rendering. I also added faces to the protons to give viewers more visual cues for how a proton is moving in 3-dimensional space and to enhance the analogies used in explaining concepts. And now I'll play a portion of the animation that we created.
Hello, my name is Dr. Erin Gomez, and this is a brief overview of magnetic resonance and a basic MRI spin echo sequence. Let's talk about protons. We have protons in the fat, muscle, and sugars within our body, and of course, within water. Remember that a significant portion of our bodies consists of water, and that a hydrogen atom is just a proton, one positron and one electron, with a positive and a negative pole. Because of this, each of these protons is capable of acting like a bar magnet. Usually, the orientation of these protons is random, but they can be influenced by an external magnetic field. At the most basic level, an MRI scanner is a giant magnet and generates its own magnetic field, which we can call B0. When protons are placed within this magnetic field, they'll line up parallel or anti-parallel to the primary magnetic field, with a small majority aligning with the direction of the primary magnetic field, just going with the flow. This generates what is referred to as the net magnetization vector. We can imagine this net magnetization along the z-axis, the long axis or length, of the patient's body. In addition to aligning with the magnetic field produced by the MRI scanner, the protons in your body are also spinning along their axes like little tops or globes. This is called precession or nuclear spin. The speed or frequency of this axial spin depends on the strength of the applied magnetic field and can be expressed by the Larmor equation. Simply put, this equation states that the precession frequency of a particle is equal to the strength of the magnetic field applied and the gyromagnetic ratio, which is a constant that is unique to each specific nucleus or element. With the protons aligned with the main magnetic field, we can influence them using externally applied radio frequency or RF pulses. When this happens, the protons are knocked down into an alternate plane and also precess together in phase. The angle depends on the strength and duration of the RF pulse. Knocking the protons down into another plane is a change in their longitudinal magnetization. Normally, the majority of protons are going with the flow and following the direction of the external magnetic field. But with a little extra energy, which we can call excitation, protons have the ability to go against the current and instead orient themselves in the opposite direction, against that of the magnetic field. This is called anti-parallel. That's not all that happens. With some energy applied in the form of the RF pulse, the protons will also precess together in phase. We can think of this brief synchronization as the transverse magnetization of the protons.
So in the planning and creation process of this animation, the needs assessment was helpful for informing our choices in presentation style. To hopefully improve learner engagement and interest, I used bright saturated colors, and to help reduce confusion, I introduced one new concept at a time and used arrows, cues, and highlights to direct the viewer's attention. Finally, I also made sure to measure and provide adequate contrast between on-screen elements to ensure user accessibility. In addition to the needs assessment, I also applied principles of the cognitive theory of multimedia learning when creating the animation. In the future, the resulting media will be available on Team RADS, which is a Johns Hopkins radiology teaching website, and will be available to the public. This animation was created based on learner feedback and will be useful to any medical students or residents studying MRI physics. Finally, I also designed a future study which will take place after the first part of this project. I will create additional media using the same assets for the animation and will compare the learner efficacies and engagement. A survey will be distributed to radiology residents as well as medical students at Johns Hopkins. We have applied for and recently received IRB approval for this future study, which will help to determine what type of media presentation style is best for teaching MRI physics. I would like to thank my preceptor, Dr. Aaron Gomez, and my advisor, Jeff Day, for all of their patience and help throughout this entire process. And I also like to thank my department faculty and my fellow classmates for all their support. Thank you, and I now welcome any questions or comments.
Hey, Emily, this is David. I just want to say, I think this is more of an observation and a comment about your characters and the kind of cartoon approach to something that's, very technical. It's going to be addressing an adult audience. I think, and this might be my naivete, I probably would have thought twice about that, but you just pulled it off beautifully. And I think part of it's because you're very clear script and your narrator, preceptor's clear delivery, and just your careful attention to the cognitive theory and the layout of the information. It just works really, really well. And I just want to compliment you. And I want to say, I know I've told you this before, your protons are like visual whoopee cushions, because you can't help but kind of chuckle when you look at them. And I can't wait for the plush toys to come out because I'm going to buy one. Really nicely done.
Thank you.
Yeah, excellent job. I, as you know, worked in radiology for a very long time, and it's such a point of stress to learn the physics for all the medical students I went through. So this is just an incredible resource that you've created. And I wanted to ask, in your material, do you also link the physics to the imaging that you're seeing, or do you focus entirely on the physics as sort of its own subject matter? And just curious behind your reasoning for that, or if it was something you considered?
At least for this thesis project, we only focused on physics as a subject and not linking it to, like real life applicability, to actual imaging. I think that would also be another area of exploration, but I think our reasoning for focusing just on the physics concepts was looking at my preceptor, Dr. Gomez's lectures for teaching MRI physics, and looking at her introductory lecture that was mostly based on analogies and not really focusing on like any artifacts or any like relationship to like the actual imaging. And I think that's where their script came from and why we chose kind of like using the characters and decisions like that.
That makes sense. And they made me dizzy watching them spin around. It's great. Like you won't forget. It runs into your mind. Excellent job.
Thanks, Lydia.
Yeah, so Emily, it was a lot of fun working with you, and you yourself had to learn this MRI physics from scratch, which is not easy. It's very abstract and can be difficult. So what are some of the things that you thought were helpful from your video? You'll get to test them out later, but what are some strategies that were helpful from your video for your own learning, you think? And then to David's point, do you want to comment a little bit more on your decision to have the characters have faces and things like that?
Yeah, I guess I can tie my answer into all of those. So, and it's kind of alluding to my answer to Lydia's question that we started out with. We decided to focus on the fundamentals of MRI physics, kind of just having a baseline so anyone watching it, if we wanted to test the efficacy, then we don't have any confounding factors of if someone is really trained versus not trained, just testing the efficacy of the media itself for teaching these concepts. But in terms of what was actually helpful for me, learning MRI physics concepts and then trying to create a resource to teach it was, I guess, obviously the faces, and I didn't get to show it in the clip today, but we created analogies with Dr. Gomez to relate the protons to little children running around, which is why they're characterized as these kind of silly, little happy, protons. So I think the use of analogies was really helpful for me in understanding the concepts, and I hope that it'll help people actually looking at the resource.
Hi, this is Erin Gomez. I just want to make a couple of comments. I want to say how proud I am of Emily for really bringing this animation to life. The MRI physics portion of the radiology core exam is notoriously challenging and fear-inducing for radiology medical students. And I think one of the biggest issues that you'll hear subjectively and anecdotally from the residents is that while there are some materials out there that have 3D visuals, they're very sterile and it's difficult to approach them. And I think putting this in the context of material that needs to be both memorable and less panic-inducing, I think her choice to anthropomorphize a nuclear particle is smart and leaves a lasting impression. And also, I just want to dovetail with what she said, that it sort of carries on in additional analogies that we have in the video in terms of these protons are like little children who must behave when the RF pulse shows up and tells them all to get it together. But I see a lot of potential here. This is relatable content. This is content that could even be potentially used to teach learners at different levels. And so I think the fact that it's approachable and engaging makes it foundational and leaves room only to build. And Emily's work ethic and just level of dedication to this, not only developing these media assets, but getting 2 IRB applications approved over the course of this is just really incredible. So kudos to her. And thank you so much, Emily, for all of your hard work.
Thanks so much, Dr. Gomez. Obviously, you were invaluable and you gave me so much help and support. So thank you so much.
Emily, I have a question for you. In your video, it goes to a point and then it rewinds. That sound sounds so much like a magnetic cassette tape. I just thought the interplay of the magnetic cassette tape and the magnet in the MRI was interesting. Did you sample that source from any particular type of media?
The sound?
Yeah.
No, but I guess maybe I'm not even old enough to really know the difference between different cassettes, but that's interesting to know.
Yeah, I didn't think you were old enough to remember, or to know, not remember. I remember. Thank you.
Thanks, Dacia. If that's it, I will be presenting my next classmate. Her name is Susie Yoon. She received her Bachelor's Science in Medical Science and Biology from Ruston University. And today she'll be presenting on the gut-brain connection in Parkinson's disease.
Thank you, Emily, for the nice introduction. Hello, my name is Susie Yoon, and could you go back to the title slide? Oh, sorry. My name is Susie Yoon, and I'm pleased to share with you my master's thesis, Educating Patients, Communicating the Gut-Brain Connection in Parkinson's Disease Using Multimedia. I would like to thank my wonderful preceptors, Dr. Ted Dawson and Dr. Valina Dawson, for their invaluable research and their tremendous support in this project. Parkinson's disease, or PD, is the second most common neurodegenerative disorder that is mostly known as a movement or motor disorder. Its non-motor symptoms are often overlooked, despite their great significance. Many PD patients have experienced non-motor symptoms, particularly digestive problems, many years before the onset of motor symptoms. In other words, they may indicate the early stages of Parkinson's and suggest more about how the disease progresses and where it may originate. Today, there is no disease-modifying therapies for Parkinson's. However, based on the research on the gut-brain connection in PD, new therapeutic targets have been identified by the Dawson's lab and have led to initiation of various clinical trials. So PD is more than a brain problem as well. While Parkinson's disease is considered a brain problem, lots of evidence suggests it may actually begin in the digestive system. The recent research into the gut-to-brain connection is focused on this protein called alpha-synuclein, which is a pathological hallmark of PD. It's a protein found inside the neurons, in the brain, as well as in other areas, including the gut tissue. The normal alpha-synuclein monomer can misfold due to a variety of causes that are not well known yet. However, one of the most possible causes is the interrupted microbiota environment in the gut due to some harmful particles released by E. coli or maybe other species as well, that causes this misfolding, which triggers cell aggregation, forming oligomers and then fibrils. These fibrils are toxic to neurons, and they can sometimes form Lewy bodies, which is a well-known pathological hallmark of PD as well, as a protective mechanism to decrease the cellular concentration of the fibrils inside the neuron. Eventually, the accumulation of the fibrils inside the neuron can cause cell death, and they can also be transmitted from cell to cell. Here you see the mouse model developed from the Dawson lab. This mouse model was used to observe the spread of the fibrils from the gut to brain via the vagus nerve. They have injected the preformed fibrils, which can be considered as an artificial form of the fibrils, into the gut tissue that is rich in enteric neurons, which have shown to transmit the fibrils towards the brain along the vagus nerve to reach the dorsal motor nucleus of the medulla. Once it reaches the DMV in the medulla, it can spread to the other regions of the brain to cause advanced symptoms of PD. So as you see, this topic of gut-brain connection in PD is really highly complex and therefore very challenging to teach the lay public without scientific background. It is even more difficult for them to understand this topic without effective 3D visual material, since its molecular conformational change of alpha-synuclein during the misfolding, as well as the gut-brain connection within the villus of the gut, are not well visually expressed in 2D. They're rather limited to oversimplified, confusing, or inaccurate diagrams. The primary audience for this project is PD patients and their families, and the lay public. The secondary audience includes researchers and philanthropists interested in funding the clinical research.
This project aimed to educate the viewers about the basic and complex concepts of PD while promoting public awareness of the early signs of PD. And here's the overview of the process and the softwares used. During each phase of the project, frequent meetings were held with my advisor and preceptors to verify the content accuracy. I've approached this project by identifying the pros of different types of media and combining them together. The main media, which is the interactive website, it houses a foundational 2D teaching module on the scientific background and basic pathogenesis of PD, followed by a narrative 3D animation that highlights recent studies in the gut-brain connection of PD. As a result, learners can navigate at their own pace through the introductory learning module prior to viewing the more complex material. As a result, I've developed a prototype of an interactive website, including 2D and 3D material. So prior to creating the interactive website, I created a flowchart, wireframe, and 2D animation storyboards. Here's the final look of the website. As you see, the first and the second page of the website has the 2D interactive animations, and the last section, called Research tab, houses the 3D animation about the gut-brain research. Likewise, for the 3D animation, a very, very rough thumbnail sketch was created based on the script, and the color storyboard was developed. These storyboard images were then animated with a raw voiceover for effective planning of camera movement and animation timing. So I have selected 2 examples. So in this scene, after defining the gut-brain axis, I made a decision at this point to keep the inset on the screen to visualize a bigger picture of the fibrils being formed in the enteric nervous system, which propagates towards the brain. As another example, I came up with an idea of using a dark overlay with a mask to highlight the path where the harmful particles pass through the villus. This helped me a lot later during the modeling and compositing phase, where I had to isolate the object buffer of an enteroendocrine cell. In order to create accurate 3D models, various reference photos were gathered in addition to research papers. Here you see the wireframe structure of the model created in Cinema 4D, and the final model rendered in Octane Render. And now, as an exciting part, I will share my final animation. Due to a time constraint, I will play only 1 minute of the animation that follows the introduction scene.
The gut is colonized with a massive community of microbes, some of which may produce harmful substances that can enter the cells lining the gut or pass through the leaky barrier. Over time, these may trigger a pathologic change to surrounding neurons in the enteric nervous system. Inside the neuron, a native protein called alpha-synuclein can misfold due to several factors, including the harmful runoff from the gut microbes. These misfolded proteins rapidly aggregate into small repeated units called oligomers, which continue to elongate and assemble into long fibrils.
In summary, the combination of interactive media, 2D and 3D visual material allows the viewer to learn the basic knowledge needed prior to understanding a complex material at their own pace. This method also helped shorten the length of the 3D animation, which is better suited for the PD patients with short attention span as a cognitive symptom. In addition, it resulted in a more efficient production for the artist myself as well, as I was able to create most of the introductory content in 2D rather than in 3D. However, there were several challenges faced during the project. First was a problem of visualizing the gut-brain connection that involves a long pathway in the nervous system. As you've seen in the final animation, alpha-synuclein undergoes a conformational change involving three-dimensional movement, so using a PDB file as a reference was essential. In terms of storytelling, it was very challenging to explain the connection between the digestive symptoms and Parkinson's as concise as possible, using a plain language for the lay audience. Future considerations will be expanding the functionality of the interactive website and publishing it online for public access. It will be even more accessible if it could be compatible in a mobile device. Implementing a user testing and possibly having an RIB approval could be better for enhanced user experience. And you can find more details about my research and watch my full animation on my website. I would like to thank my co-preceptors, Dr. Ted Dawson and Dr. Valina Dawson from the Johns Hopkins Institute for Cell Engineering. David Rini, my faculty advisor, for helping through all the phases of my thesis project. Donnie Blease, my technical advisor. Vesalius Trust for funding this research. Faculty of Art Applied to Medicine, class of 2021-2022. William Guzman for building my first ever custom PC. Thank you. I will now welcome any questions or comments.
Yes, Susie, this is David. It was great to work with you on this. I do want to point out, you mentioned it right at the end, but I just want to, I guess, compliment you or comment on the fact that right before thesis started, Susie decided that she wanted to have access to a third-party renderer to create the effects that she wanted to be able to create in her thesis. And I think at one point asked my opinion as to whether or not she should build a PC. And I very thoughtfully said, absolutely not, right before thesis. So she went ahead and did it. And I just want to compliment you. I think you were organized about that. And I think that not only have you learned a lot in terms of new software, how to build a PC, but I can really see an effect in your final product and being able to use the renderer. And I think that, the effects show in your final work. So well done.
Thank you, David. It was fun. It was really fun learning new stuff in this project.
I had a similar question, Susie. This is Jeff. First of all your renders look so beautiful. They all look like candy. The proteins look like licorice. They look delicious. Yeah, I remember that William used like outside rendering sources. So I was curious if you rendered everything on your computer, or did you get to plug into the school's farm, or did you use something else?
I did run out of time in the end. So I tried the third-party render, but they didn't really work with my render engine. So all of the animation that I showed for today is from my PC, which took like a tremendous time.
You made it work very hard.
Thank you, Jeff.
Hello. So I'd just like to say, Susie, you did a fantastic job. And you mentioned it, but probably people didn't fully understand that there were no images of the anatomy of the gut and the innervating neurons. And you really did a great job with looking at histologic samples and producing something that's really novel and very useful for our field. And so I think it was just absolutely, it was very creative, but you really did a lot of digging into the scientific literature and the histology that was really, really impressive. And I know that our colleagues are going to find this, this animation not only informative, but they're just going to be like, wow. So thank you very much. And it was so much fun working with you. You're really a terrific and beautiful person.
Oh, thank you, Dr. Dawson. Thank you for all the research papers that you provided me with. Really helped me dig into the research a lot.
Yeah, this is Ted. I just like to second what Valina said. It's just really fantastic and phenomenal, and taking these really difficult molecular issues. You know, it's not at a proton level, but you know, these are still very complex problems that are not only difficult for patients to understand, but I can tell you they're difficult for students, and a lot of our peers don't understand the concept of this synuclein misfolding. And we can't wait to be able to use the videos that you've made in some of our presentations to patients, students, and scientists. So thank you. It's a really fantastic job.
Oh, thanks for the sweet comment. I will make sure to make it even better when I give it to you. I can wait 10 more seconds for comments, and then I will move on. Five seconds. Okay. Now I will introduce you to my wonderful classmate, Laura Eckel. She studied biological and pre-medical illustration at Iowa State University, and her thesis is about visualizing the tumor vasculome.
Thanks, Susie, for the introduction. Hi, my name is Laura Eckel, and the last thesis presentation that we'll have today is titled Mapping the Tumor Vasculome, a novel interactive 3D visualization of computationally derived tumor hemodynamics. I would like to thank my thesis preceptor, Dr. Arvind Pathak, and my faculty advisor, Lydia Gregg. Cancer is currently the second largest cause of death worldwide. Understanding how to fight cancer relies on our ability to understand tumors, how they're similar, and just as importantly, how they're different. Tumors exhibit a large range of inter- and intra-tumor heterogeneity, including morphological, functional, and genetic components. Taken together, the heterogeneity in these parameters leads to the creation of distinct tumor microenvironments, or the TME. TME heterogeneity directly affects tumor progression, treatment resistance, and prognosis. The tumor microenvironment is directly affected by the tumor vasculome, which describes the web of complementary factors that characterize a vascular tree, including morphologic features like vascular length and functional hemodynamic parameters like blood flow rate. In normal tissues, the vasculome is predictable and homogeneous, but in tumor tissues, the vasculome is highly heterogeneous. Research into the form and function of the tumor vasculome is an exciting avenue to potential new cancer treatments that target vascular growth, as well as for investigating its role in cancer progression and metastasis. Recently, a study by the Pathak Lab used multi-scale imaging to demonstrate the spatiotemporal heterogeneity in the vasculomes of an ensemble of preclinical breast cancer models. Visualizations reproduced during the study show the structural and functional parameters of that ensemble. The results of this study provide the foundation for a novel cancer atlas for understanding tumor hemodynamics. These data are the basis for my thesis project. The primary goal of my thesis was to design a prototype for an interactive web-based 3D visualization of the tumor vasculome data generated in the 2019 study. This goal is supported by the following objectives: to create a reproducible workflow that uses multi-scale imaging data and simulated hemodynamics to visualize the included morphological and hemodynamic components of the vasculome in 3D space. Communicate the fundamental definitions of key hemodynamic concepts, and utilize best practices for web accessibility, usability, and data dissemination to allow researchers to interact with the vasculomes. The primary audience for this interactive is cancer researchers studying tumor heterogeneity. Secondary audiences include graduate and undergraduate students and their instructors. A variety of software and web packages were used to create the products of this project. I'll describe their purposes in the following slides. To start, I segmented the tumor and soft tissue surfaces from a representative tumor from an MRI dataset provided by the Pathic Lab in Amira, then refined and optimized the surfaces in ZBrush. Didactic content describing fundamental hemodynamic concepts was developed with Pathic Lab members after reviewing the literature. I created sketches for the didactic illustrations and modeled the scenes in Cinema 4D and rendered them as stills. These stills were imported into Photoshop for adjustments, and text and labels were added in Illustrator to create the final illustrations. To map out the interaction of the planned web application, I created a flowchart in Draw.io. The main functionality of the web application was organized into two main segments seen in blue and green boxes on the image. Blue for visualizing the tumor data and green for communicating the hemodynamic concepts. Based on the flowchart, I created low-fidelity wireframes in Adobe XD and iterated on them based on feedback from members of the Pathic Lab. I created high-fidelity wireframes in Adobe Illustrator. Here we see some of the icon, color, and menu styles defined for the prototype, which contributed to the prototype wireframes and animations. The tumor and healthy vasculome data sets to be visualized were stored as spatial graphs. These files contained hundreds of thousands of points, each with multiple associated parameters, resulting in a complex and large data structure. The interactive visualization for the prototype was developed in PlayCanvas by Russ Adams at Isoform. The 3D visualization corresponding to the data structure on the left is shown in the image on the right. The vasculome data was optimized to remove points that were very close together, and simple cubes were mapped onto the center lines to keep total geometry as low as possible. There were several results from this project. During the content writing, 2 novel formulas for length and diameter were written, and 2 3D models were created. 10 didactic illustrations were created, along with the UI/UX design for the prototype. Here we see one of the final illustrations for intravascular oxygen tension, which is a measure of blood oxygen saturation. There is a direct comparison between healthy tissue that is adequately oxygenated, indicated by the red hues, and tumor tissue with a low PO2 shown in purple. The variables that are used in the formulas to calculate intravascular oxygen tension are integrated into the illustration and are consistently color-coded throughout the interactive to help the user draw relationships between the variables. Here is another illustration for intervessel distance, which is the distance from any point in the tissue to the nearest blood vessel. The illustration shows 2 healthy blood vessels and an overlay for the distance to the nearest vessel, with blue being close to vessels and green being further away. This illustrate incorporates research imaging from healthy and tumor tissues to connect the microscopic concept to the larger tissue, where the healthy tissue is primarily blue and has a low and consistent intervessel distance, and the tumor has uneven patches and areas of hypoxia. This video shows the prototyped interactivity in combination with the 3D visualizations developed by Isoform. On entry to the interactive, a default healthy tissue is loaded and can be interacted with in 3D space. The user can select from other tissue samples, including the breast vasculomes. For the tumor samples, the tumor and soft tissue surfaces can be overlaid. Different variable maps can also be overlaid onto the blood vessels. Annotations that mark key microenvironments display when the associated variable is shown. These annotations link the user to the corresponding didactic section, which they could also navigate to using the tabs at the top of the main menu. In each didactic section, the unit, symbol, and definition are given. The illustration can also be expanded. Furthermore, the mathematical formula, a list of hyperlinked references, and buttons to related parameters are given, enabling the user to easily explore related hemodynamic principles. We can see that the user has jumped to the section on vessel length. The user can also access auxiliary functions with the icons around the screen, including a contact form to reach out to the Pathic Lab. Visualizing the spatial graph required a creative solution because of the size of the data sets. Solutions within Amira and Unity were attempted, but without success. Ultimately, we shared the data with our colleague, Russ Adams at Isoform, for his advice, and he solved the 3D projection problem by writing custom JavaScript code in PlayCanvas. This WebGL game engine was optimal for its ability to upload the spatial graph file type and allowed custom JavaScript code. The final illustrations and application mockup will be displayed on the preceptor's site, and the illustrations created can be used in presentations. In the future, the full functionality of the web application could be completed beyond the prototype. Healthy or pathologic tissue samples can continue to be added, and lymphatic vessels or other TME components can also be explored. Ultimately, this novel workflow can be applied to imaging data to enable further study of cancer and other tissues, opening the door to new insights about disease, process, and treatment. I would like to thank my thesis preceptor, Dr. Arvind Pathik and Dr. Akanksha Bhargava in the Pathic Lab for sharing the opportunity to work with their amazing data and for answering my many questions, and my department advisor, Lydia Gregg, for her constant support and insight. I would also like to thank Russ Adams from Isoform for his contributions to this project. Thank you to the Vesalius Trust for Visual Communications in the Health Sciences and the National Cancer Institute for their generous support of this project. I'm happy to take any questions or comments.
I just wanted to start out by congratulating you, Laura. You did an excellent job and it was great working with you. And I also just wanted to highlight the fact that you have so much to talk about what you accomplished here, but Laura has a background in mathematics and was able to actually define 2 of the formulas specifically for her thesis. And also it's amazing how much work you handled with modifying and optimizing that spatial graph so that Russ could handle it and work with that in PlayCanvas, which was excellent. And I think it just really highlights the value of the scientific knowledge that we try to bring to the profession as medical illustrators. So congratulations.
Thanks, Lydia.
Hi, Laura, this is Arvind Pathak. Again, I just wanted to say this is like a tour de force of visualization, and you've taken our engineering vision and translated into these really stunning visuals and laid the stage for a platform that we'll be exploiting and completing, hopefully, for years to come, both in the computational domain and the systems biology domain, all informed by your, astute illustrations, your attention to detail regarding the information flow, and of course, working with a bunch of engineers who know very little about illustration. So congratulations on a really stunning piece of work, and thank you for everything that you did with us.
Thank you so much for your kind words, Dr. Pathik, and thank you again to Akanksha for all of her help with the project. So thank you so much. Okay. Well, I'd be happy to take any final questions or comments. You can also leave them in the YouTube chat. I know that we're a little bit over time, so on the behalf of the class of 2021, I just want to thank everyone who joined us today, particularly our faculty advisors, the staff in the Department of Art as Applied to Medicine, especially Daisha Balch, and our faculty preceptors for our master's thesis projects. Recordings of these presentations will be available on the department YouTube channel. I thank you and I hope everyone enjoys the weekend.